morning. Let me first thank the organizing committee to give me this opportunity to talk to you about second opinion in breast cancer. And second opinion in breast cancer pathology usually is requested when a patient is referred from another institution for treatment, either surgery, chemotherapy, or whatever, no? And it should be seen as an opportunity to detect diagnostic errors that impact on patient management, but also as an opportunity to reassure to the clinicians, the management team, that what has been done is either right or wrong. So who is requesting a second opinion in breast cancer? I think this varies from institution to institution and also from different situations. Like in my institution, I guess I get most of the second opinion requests by medical oncologists and also breast surgeons, but even patients and other pathologists at one time or another may request for a second opinion. No? Depending who is requesting the second opinion puts more emphasis on certain aspects of the problem. No? And then there are very well established prognostic factors in breast cancer that we have to check. And this, you know, includes tumor size, tumor grade, histological type, margins of resection, lymphovascular invasion, proliferative index, lymph node stage, predictive markers. And for instance, medical oncologists, at least in my place, they are always very interested in predictive markers. Surgeons are very interested in confirming that this is a malignant disease and the status of margins and so on. No? So breast cancer management is a team effort, and different specialists are working to make it a success. No? And we pathologists are, you know, we work in basements. We are at the very base. No? So if we do something wrong, the whole structure may collapse. No? So we better be careful with what we do and say. So when we review cases for as a second opinion, there are a number of questions that comes into mind, and depending on the case, they will be more prominent than others. First question is it really cancer? I mean, it seems like an obvious question, no? But it has to be considered. Is it really breast cancer? Is it an invasive cancer? Are the margins of resection free of disease? Are the predictive markers of response accurate? And then there are a number of special situations. We see patients with a previous history of breast cancer that present tumors in other organs, and everybody assumes that it has to be a metastatic disease, but it's not always the case. And the opposite is true. Patients with history of non-breast cancer that present a breast lesion, and everybody thinks that this is a new tumor, and it's not always the case. And then we see patients presenting with tumors in the axilla without an evident breast lesion, and this can be also problematic because this can be metastatic tumors to axillary lymph nodes from different places. They can be metastases from occult breast cancer, or they can also be primary tumors of the axilla that either has nothing to do with breast tissue, they arise in ectopic breast tissue, they may arise from sweat glands and skin appendages. Dr. Masoud already mentioned some of the things I want to put forward in this talk, and one is really what we know about the diagnostic concordance among pathologists, and there is this interesting study just published in JAMA this year, where a good number of pathologists study sets of cases, and their diagnosis was compared with the expert diagnosis. And really the group of diseases that were studied is benign lesions without atypia, atypical hyperplasia, ductal carcinoma in situ, and invasive cancer. And then I put here some histological examples so you get an idea of the problem. For instance, this is a very proliferative lesion that I don't consider it to be atypical when I really study in detail in the microscope. This is an sclerosing lesion that has the potential to mimic invasive cancer. And this is the problem that Dr. Masoud already talked about, and is how close the morphology of atypical ductal hyperplasia and ductal carcinoma in situ of low grade how close they can look alike. No? So the results are really fascinating because you can see that the best concordance, thanks God, was obtained for invasive carcinoma, like 96% agreement. But with some cases that were underinterpreted, 4%. DCIS, 84%, but there was overinterpretation in some cases, that is, cases of carcinoma in situ that were considered to be invasive. And also underinterpretation, cases of carcinoma in situ that were not recognized as cancer. Worst agreement, atypia, no? And this is understandable, no? And benign lesions without atypia also had the potential to be overinterpreted. So why do pathologists disagree in the diagnosis of breast lesions? And this, I don't know. I mean, I don't really think that nobody knows for certain, but really I think some of the reasons are because we have different levels of training and experience. We have different levels of interest in breast pathology. And then the interpretation of borderline or gray zone cases is problematic. Occasionally we see rare cases that is very difficult to have experience. The clinical situations sometimes are peculiar, and that make us make mistakes. And also there are technical issues. I mean, it's not only the pathologist interpreting, but the industry, what kind of antibody, what kind of machines we work, and etc. So we can classify the second opinions as concordant when we agree with the previous diagnosis. And this group, major discrepancies, that's what we say when really the error has the potential to change the prognosis or the treatment of the patient. And then there are minor discrepancies that really don't impact on treatment or prognosis. And I have here summarized several series from the literature, and the series are really different. Each one, the setup is, how the cases are collected, etc., is different. But I think, for instance, the experience of MD Anderson, where they review every case that was sent to the institution, gives a figure of major discrepancy of around 11%. And this is really a good guide of the magnitude of the problem that we might have. I try to group our cases, no, and see what kind of discrepancies we had, no, and then we have like a third of the cases is really a change in the histological diagnosis, in the type of tumor, and then there is a group of cases that the problem is distinguishing invasive from ductal carcinoma in situ of different degrees of invasion and ductal carcinoma in situ. And then Another third is around the predictive markers, estrogen receptor and HER2. And this is a little bit messy table, but here I have tried to reflect many of my cases. And you can see that there are cases that were called invasive and that were benign, problems in distinguish between breast and lung cancer, mistakes with axillary tumors, change in the classification of some histological type of breast tumors. For instance, a Phyllodes tumor turned out to be a spindle cell carcinoma, an adenoid cystic carcinoma turned out to be a cribriform carcinoma, and so on. Are we far from it? Okay. This is just an example of an axillary mass in a 30-year-old woman, and she was considered to have metastatic breast cancer, and the surgeons started to look at her breast. But really, she had metastatic lung cancer, and by immunomarkers, we were able to make this diagnosis, and the patient was adequately treated, studied, and treated. So immunohistochemistry is helping us a lot to distinguish, for instance, in this case, lung and breast cancer, but we have panels for other tumors, and we should really use, when needed, this. And the last main group of discrepancies are receptors and HER2. And I think the reasons why there are problems with this is because the technical problems, and also because of interpretation problems. And estrogen receptors really is not difficult to interpret, but we have to understand that any degree of positivity, it's important so the patient could benefit from treatment. And this is an example of negative, focally positive, so this focally positive we have to catch up. And then HER2, I don't think we have time for that, but we have new guidelines now that we have to follow to be accurate. And then I go to conclusions. Major discrepancies in the evaluation of breast cancer reports are often related to the assessment of the degree of invasion of breast carcinoma, immunohistochemical results, the assessment of axillary lesions and distant metastases in patients suspected of having breast cancer or with a history of treated may reveal non-mammary tumors. We have to take that into account. And I think significant improvement in the concordance among pathologists in the assessment of breast lesion can be achieved by careful histological study to follow standardized criteria, have complete clinical information, and use good quality immuno techniques and markers. Thank you very much for your attention.